Assalamualaikum warahmatullahi wabarakatuh to everyone. My name is Siti Radhiah, and today I am going to explain and evaluate two radiographs, which is AP and lateral radius ulna. So first of all, I would like to explain what is radius and what is ulna. So radius is one of the two large bones of the forearm. It extends from the lateral side of the elbow to the thumb side of the wrist, and it is also parallel to ulna. So next is, what is ulna? Ulna is shorter and smaller than radius. It extends from the medial side of the elbow to the side of our pinky finger, and it is parallel to radius. So next, I'm going to evaluate the first radiograph, which is AP radius ulna. So why I said this is AP radius ulna? This is because radius and ulna are seen parallel to each other. Ulna and radial styloid are in profile. The wrist and elbow joints are clearly demonstrated, and medial and lateral humeral epicondyles are seen in profile. So next is positioning. So this is the correct positioning for epiradius ulna. So why? This is because first, radial styloid demonstrated in profile laterally, radial tuberosity demonstrated in profile medially, olecranon process situated within olecranon fossa, humeral epicondyles are seen in profile, radial head superimposed with radial tuberosity by 0.6 cm, and lastly, superimposition of metacarpal bases and radius ulna is minimal. So next is the incorrect positioning of epiradius ulna. So for this radiograph, the hand is externally rotated because you can see that radial head superimposition with radial tuberosity is less than 0.6 cm, and the humeral epicondyles are also seen not in profile. So the improvement for this radiograph is rotate patient's hand internally until humeral epicondyles equidistant to the tabletop. So next is the radiograph, the incorrect positioning, which is the hand is internally rotated. I say so because the radial head superimposition with radial tuberosity is more than 0.6 cm. Radial styloid not in profile laterally, and humeral epicondyles also seen not in profile. So the improvement is rotate patient's hand externally until humeral epicondyles equidistant to the tabletop. Okay, next is the alignment. So first is the alignment for extray tube with patient. It is cannot be determined because there is no four borders of collimation. Next is extray tube with cassette, also cannot be determined because there is no four borders of collimation. Meanwhile, for cassette with patient, it is incorrect because the distance between central structure at the right side is bigger than the left side. So, the centering point for this radiograph cannot be determined because there is no four borders of collimation. So the standard centering point for this projection is at mid-radius ulna. So next is collimation. So the red part is for superior, blue is inferior, and green is lateral. So I'm going to go through the superior part. So the structure that should be included in superior part are radial tuberosity, olecranon process, and proximal radio-ulnar joint. For inferior, structure that should be included are radial head, distal radio-ulnar joint, and ulnar styloid. And for lateral border, structure that should be included are lateral epicondyle, medial epicondyles, and radial styloid. So next is exposure factors. So first is for bony cortical outline. First of all, the thick structure for epiradius ulna is the olecranon process, while thin structure is ulnar styloid. So first is for bony cortical outline. For olecranon process, it can be seen, so no changes needed. For thin structure, which is ulnar styloid, also can be seen, so there is also no changes needed. Next is for bony trabecular pattern. For the thick structure, which is olecranon process, can be seen, so there is no changes needed. And bony trabecular pattern for the ulnar styloid also can be seen, so there is also no changes needed. Next is marker. In this radiograph, there is no evidence of anatomical marker. So, the thing that we need to do is the annotation of the marker should be left side and placed on the left side of the body, not superimposing any region of interest. So we can put the marker here or here within the collimated area. So next is aesthetic. So for this radiograph, film size used cannot be determined because I get it from the internet. So the best size film size used is 35 times 43 centimeter. It is the appropriate size of the film because radius ulna is categorized as lomboid. And lastly, for the evaluation based on placement is name. So for this radiograph, it does not have ID and adequate information about the patient on the radiograph. So we should place patient's information at right or left side of the radiograph, not superimposing any region of interest. And lastly, the conclusion for that radiograph is unacceptable because it does not have patient's name, ID, date and place of examination, and there is no evidence of anatomical marker on the radiograph. So next, I am going to evaluate a radiograph of lateral radius ulna. I say so because distal of radius ulna are superimposed with each other. Ulnar styloid demonstrated in profile posteriorly. Radial tuberosity is not demonstrated in profile. So the positioning for this radiograph is correct. Why? I say so because elbow is flexed 90 degrees, radius and ulna superimposed at distal end, humeral epicondyles align perpendicular to the IR, distal scaphoid slightly distal to pisiform, and lastly, radial head and coronoid process are seen superimposed with each other. So this is the example for incorrect positioning of lateral radius ulna. For this radiograph, the hand of the patient is internally rotated. This is because Radius and ulna not superimposed at distal end, and radial tuberosity seen posteriorly to the ulna. So the improvement for this radiograph is rotate patient's hand externally until radial styloid and ulnar styloid perpendicular to the IR. So next is this radiograph shows that the hand of the patient is externally rotated. I say so because radial tuberosity is seen anteriorly. So the improvement of this radiograph is rotate patient's hand internally until radial styloid and ulnar styloid perpendicular to the IR. So next is the alignment. So the alignment for X-ray tube with patient and X-ray tube with cassette cannot be determined because there is no evidence of four borders of collimation on the radiograph. Next is the alignment for cassette with patient. It is incorrect because the distance between central structure at superior border is bigger than inferior border. So the centering point for this radiograph cannot be determined because there is no four borders of collimation. The actual standard centering point for this radiograph is at mid-radius ulna. So next is collimation. For superior border, structure that should be included are ulnar neck, coronoid process, and radial head. For inferior border, structure that should be included are ulnar styloid, radial head, and pisiform. While for lateral border, structure that should be included are radial neck, radial tuberosity, and olecranon process. So next is exposure factors. For the thick structure for lateral radius ulna is the coronoid process, while the thin structure is the pisiform. So the bony cortical outline for the thick structure, which is coronoid process, and the thin structure, which is the pisiform, can be seen. So there is no changes needed. While the bony trabecular pattern for the thick structure, which is the coronoid process, and the thin structure, which is the pisiform, also can be seen. So there is also no changes needed on the radiograph. So next is marker. In this radiograph, there is evidence of anatomical marker, which is the plumbar marker. It is correctly placed on the left side of the hand, and it is also not superimposed with region of interest. So next is aesthetic. The film size used is 35 times 43 cm, which is sufficient to demonstrate structures of the interest. It is the appropriate size of the film. It has an artifact which is scratch mark but not superimposed region of interest. I say so because this is the real radiograph that I get from the image critic lab. So next is there is also external artifact, which is hospital tag or tag of patient's identification at patient's metacarpal basis. So next is lateral radius ulna for name evaluation. There is no evidence of patient's ID and information on the radiograph, maybe because of patient's privacy. So we should place patient's information at the right or left side of the radiograph, not superimposing any region of interest. So the conclusion for that radiograph is acceptable. I say so because first, there is evidence of anatomical marker on the radiograph. There is no evidence of rotation, and there is also patient's ID and information, even though it is not shown on the radiograph because to respect patient's privacy. So this is the references that I use to evaluate those radiographs. This is based on Harvard referencing system. So that's all from me. Thank you for listening. Assalamualaikum.